I kind of forgot about that first week that we had back in early January. So, welcome. Thank you for being here. We've got a few important issues to discuss, and I will go ahead and call this meeting to order and ask DJ to please take the roll.
Representative Bentley. Yes. Representative Bratcher. Yes. Representative Bray. Present. Representative Burke.
Present.
Representative Callaway.
Present.
Representative Dotson.
Present.
Representative Duval.
Present.
Representative Frazier Gordon. Representative Justice. Representative Neighbors.
Here.
Representative Rayborn.
Here.
Representative Raymer.
Here.
Representative Riley. Here. Representative Rourks.
Here.
Representative Sharp.
Present.
Representative Swan.
Present.
Representative Weber.
Here.
Representative Wilner.
Here.
Representative Witten.
Here.
And Chair Mosier.
I am here. We have a quorum established to do business. So again, welcome to everyone. If I could just remind everyone to please silence your cell phones. And we do have a few members who are also members of state government. So if you see people running in and out through the meeting, that's what that's about. So we will just ask that anyone who leaves, if you need to record a vote, just let us know when you come back, as long as we're not in the middle of another vote. Are there any members who would like to introduce any special guests? Representative Weber.
Thank you, Madam Chair. I would like to recognize Nicole Fries here today. She's sitting in the front row. Nicole is an RN who's participating in a shadow program today to follow a state legislator so that when she begins to advocate for her profession, she understands what happens in the life in the day of a state legislator. So we want to welcome her here. I gave her copies of both bills, so she's read them thoroughly. So she's well versed on what we'll be talking about.
Well, welcome.
Thank
you for being here. Okay. All right, seeing no further introductions, we will go ahead and take up some of the regulations. We have 3 regulations to consider. I'd like to discuss 908 KAR 001374 first, because we do have an agency amendment. I know that we have Rachel Ratliff here to discuss the regulation, and if you could just make your way to the table, introduce yourself for the record, and just discuss the changes that were made to the reg, and maybe a brief explanation.
Hi, I'm Rachel Ratliff, and I am the Regulation Coordinator for the Department for Behavioral Health, Developmental, and Intellectual Disabilities. As you know, we met with you earlier to address some continued concerns after the amended after comment statement of consideration version to remove the limitation of 300 patients per provider, and then to also strike on-site for clinicians so that it was just medical professionals be available to treat and take care of patient needs. So it was more to be to allow the NTPs and OBOTs to be able to function a little bit easier with the staffing challenges that they're currently faced with.
Okay. Yes, thank you, and I appreciate your work on this. And the regulation has to do with alcohol and other drugs and the treatment provided. And we're talking about the physicians and practitioners who are treating addiction medicine and prescribing buprenorphine. So just to clarify that these are changes that we advocated for. There was a 300 patient cap on addiction treatment providers, and we don't do that for other medical specialties. And so we thought it was important to be able to provide that treatment for those patients. So I appreciate your work on this, and thank you for the explanation. Do we have any questions from committee members? Okay. Seeing none, I will just entertain a motion to approve the reg as amended. Representative Bratcher. And a second, Representative Wilner. Thank you so much. All in favor, please say aye. Aye. Any opposed? Okay. All right, the motion passes. Thank you so much.
Thank you.
We have two other regs that have come through the public comment period and are without any sort of opposition or discussion. Did all members have a chance to see those? Are there any questions? All right. Seeing none, I will consider those reviewed. The first item on our agenda today is House Bill 125, an act relating to public health. I would like to, at this time, invite Representative Rebecca Raymer to the table, and any guest. I think we have Mackenzie Wallace. Thank you very much for being here. Please introduce yourselves for the record and proceed with your discussion.
I'm Representative Rebecca Raymer, District 15, and I have my guest is Mackenzie Wallace. And you want to introduce yourself?
Yes, thank you so much, Madam Chair, members of the committee. Mackenzie Wallace, Director of Public Policy for the Alzheimer's Association.
So this is a straightforward, simple but important piece of legislation. House Bill 125 will require the Department for Public Health to work with the Office of Dementia Services to incorporate information on brain health and risk reduction into materials the state publishes and distributes to the public on heart disease, stroke, diabetes management. We know that of Medicare beneficiaries with dementia, 95% of those people have at least one other chronic condition.
Okay, we have a motion and a second on the bill. Are there any questions from the committee members? Okay. Oh, we do have a sub. Sorry. So we need to adopt a committee sub. Thank you. We have a motion and a second on the sub. All in favor of adopting the sub?
Aye.
Any opposed? Okay. Do you want to just briefly tell us what the sub does?
Yes, there was just a minor change. So originally we had these updated integrated materials being sent to all 61 local health departments by the Department for Public Health. And we wanted to add that the Department for Aging and Independent Living will take the sort of other side of the coin, and they'll make sure that these materials are getting out to our area agencies on aging and our senior centers. As we know, those are very, common places, especially in our rural and underserved areas, to get information.
Okay, thank you. All right, now, do we have any questions or comments from the committee? Okay, seeing none, DJ, please take the roll.
Representative Bentley. Yes. Representative Bratcher. Yes. Representative Bray. Yes. Representative Burke.
Yes.
Representative Callaway.
Yes.
Representative Dotson.
Yes.
Representative Duval.
Yes.
Representative Frazier Gordon. Representative Justice.
Yes.
Representative Neighbors.
Yes.
Representative Rayburn. Representative Raymer.
Yes.
Representative Riley. Representative Rourks.
Yes.
Representative Sharp.
Aye.
Representative Swan.
Yes.
Representative Weber.
Yes.
Representative Wilner.
Yes.
Representative Whitten.
Yes.
And Chair Mosier.
Yes. Okay, House Bill 125 passes as amended by the House Committee sub and passes with favorable expression, 19-0, and should do the same on the House. Thank you, and
Thank
congratulations
you, Madam
on
Chair.
your first bill.
If I may have one moment of privilege, I'm going to embarrass some first-year law students that are here with me today. I mentor them. They're at the University of Louisville Brandeis School of Law, and they are sitting in the audience with me today, Andy and Lily. So please feel free to come up afterwards and impart some words of wisdom on them. Thank you so much.
Thank you. Thank you, Mackenzie. Thank you for being here with us. Okay, the next bill we will take up is House Bill 180. And I will make my way to the table to discuss this legislation. If I could have my vice chair just take over.
The next bill that we're going to be hearing today is House Bill 180 with Rep. Mosier. And I'd like for you to introduce yourself and your guest for the record, please.
Yes, sir. Thank you, Mr. Chair. And I appreciate the opportunity to be here to discuss House Bill 180 today. I am Representative Kim Mosier of the 64th District, and I have some special guests with me today. I'll have them introduce themselves for the record.
Hello, my name is Leah Phillips, and I'm from Oldham County, Kentucky, and I'm a patient advocate.
Hello, I'm Dr. Michael Gieske. I'm a family practice provider, been in practice for 36 years. I'm also the director of our lung cancer screening program at St. Elizabeth Healthcare.
All right, thank you. And again, thank you for the opportunity. House Bill 180 is about getting the right medical treatment at the right time, saving precious time, saving healthcare costs, and saving lives. Most of us have been touched by cancer in one way or another, and we've seen our loved ones go through the devastating effects of chemotherapy. And unfortunately, Kentucky still ranks as #1 in the nation in lung cancer. We also have abnormally high rates of other cancers and, of course, chronic diseases that we hear a lot about. And I think most of us have experienced a situation where we were prescribed a medication and it didn't work. We needed another type of medication to really figure out what worked for us. And so this is really the crux of this bill. We know that oftentimes these treatments are historically the best treatments for a category of cancer or even medications for other diseases, but they are not targeted treatments for specific for a patient's specific genetic makeup or their biomarker. So we need to better understand how patients respond to medications, what their biomarkers are, and how they metabolize medications. And that's what this will do. This testing allows for precision or targeted treatment, less trial and error, and of course, less of the devastating side effects that we see, and premature death. We know that these biomarker and pharmacogenetic tests are evidence-based. They are standards of care for many cancer patients and others, and they must be medically necessary in order to be prescribed. But the insurance coverage is failing to keep pace. This testing analyzes a patient's tissue, blood, or other biospecimen for their biomarker. Biomarker testing helps the physicians and practitioners who are treating patients to best determine the right treatment for the patient. This, of course, results in improved quality of life, better health outcomes, and reduces the overall cost of treatment. House Bill 180 requires health benefit plans to cover biomarker testing ordered by a healthcare provider for the diagnosis, treatment, management, or monitoring of a patient's condition. And there's currently limited and disparate coverage for biomarker testing because of a lack of consistent insurance coverage. And not only that, that's for everyone, but it especially affects the minority populations, Medicaid eligible populations, and rural populations where there's less access to this care. So this puts certain populations at a significant disadvantage. At this time, I will hand it off to, I don't know who would like to go first.
Ladies first.
Okay.
Thank you. Again, I'm Leah Phillips, and in December of 2019, I was diagnosed with stage 4 lung cancer as a never smoker. At time of diagnosis, they told me 6 months to a year was my life expectancy at 43 years old as a healthy female. The oncologist we met with suggested biomarker testing, which my husband and I had never heard of, but they assured us that this would give me the best chances for quality care. So at that point, I had a biomarker test performed on the tissue from my lung nodule, which came back positive for a biomarker called EGFR exon 19, basically meaning that somewhere along the way, that gene stopped working and allowed the lung cancer to grow. By having that biomarker testing performed, I qualified for Tagrisso, which is a targeted therapy or precision medicine to treat my cancer. Had I not had the biomarker testing done, I would have been treated like a typical lung cancer patient, most of which are smokers, and been put on chemotherapy and immunotherapy. If I would have chosen that route of treatment, my life expectancy and my quality of life would be much decreased. Not only did I have biomarker testing done at diagnosis, my type of cancer, it's not a matter of if it comes back, it will return and progress. At that point, the doctors will want to re-biopsy or re-biomarker test that tissue to see if there are any other new genetic markers that have developed that would qualify me for a different TKI or additional treatments to target into that therapy. So not only is this important in guiding my treatment plan, but it's also allowed me now to live for 38 months since diagnosis with now the life expectancy of 5 to 7 years. So it is a big difference, and it is extremely important. Luckily for me, my husband and I are both educated and are researchers and know this is what needs to be done, but people that are of different ethnicities and economic levels should be entitled to the same treatment that I receive. So thank you.
Great. Thanks again for the opportunity to be here. We're also represented here today by the American Cancer Society and the American Lung Association and a few patient advocacy groups that I would like to briefly mention. The Breath of Hope Kentucky and Stages, and also the HEAL Collaborative that drove up here, 2 gals from Georgia. I come from a background of family practice. I've been in practice for 36 years, and unfortunately, I've seen a lot of cancer, and I've seen a lot of families affected by cancer. I became more intimately involved in the oncology space back in 2016 when I joined the Thoracic Oncology Disease Management Team as a primary care representative for their work. At the time, I didn't know what a lung cancer screen was. I found out that finally we had something that could make a tremendous difference in the lives of our patients that were at risk for smoking or at risk for cancer and that had lung cancer. We started going after it, and we have made a tremendous difference. We've built a very aggressive and busy lung cancer screening program. We're going after it, and we're finding it in the early stages. We find over 70% of lung cancer now in stage 1. Equally as important and equally great, really, is that even when we find cancer in the later stages, stage 3 and stage 4, we can make a tremendous difference with those patients. The treatment for these patients now, as Leah alluded, is much different than it was just 5 to 10 years ago. And it's important that we convey that message to not only our patients and their families, but to the community and to our legislators. This is something that can make a big difference. One of the problems, though, is that even with lung cancer screening, there's still 55% of the population that gets lung cancer that doesn't meet screening criteria. The good news is that these patients, many of them, have a targetable mutation and do respond to precision medicine and targeted therapies. Even the patients that we find through our lung cancer screening program have these same targetable mutations oftentimes and can respond to targeted therapies. We're making a tremendous difference with these folks. This treatment can be miraculous, as Leah has alluded. We have patients now that are 5, 10, 15, even 20 years out from their cancer diagnosis with late-stage lung cancer, stage 3 and stage 4, that have no evidence of disease. And most of those patients are able to say that because of targeted therapies, because they had biomarker testing. We didn't used to have many lung cancer survivors. They didn't have a strong advocacy group because they didn't live long enough to be an advocate. And those that did were so sick and so beaten down from their treatment that they weren't able to if they wanted to. We now have a very strong advocacy movement in the lung cancer screening space. Their voices are loud and strong, and their numbers are growing. And I think that's why you're beginning to hear more about lung cancer, biomarkers, lung cancer screening. It's getting some of the same attention that it deserves now that colon cancer and breast cancer gets. Leah Phillips is here as a result of her targeted therapy. I want to mention a gal that's become a friend of mine through this advocacy work that I've done, Chastity Harney. She was diagnosed with adenocarcinoma stage 3C when she was 40 years old. She has 3 children. She underwent biomarker testing, and she also had a targetable mutation, the EGFR mutation. She received targeted therapy through precision medicine. She just had her 4-year scan of her brain just last week, and she's clear of disease. These are the kind of stories that we're hearing more and more, just remarkable life stories. Chastity's daughter got married the same month that my daughter got married, last October. She would not have been able to see her daughter's wedding, most likely, if she hadn't received this biomarker testing and precision medicine therapy. This technology exists. It's evolving. Policy needs to keep up with the change. It's exciting. It's really changed the way that we look at cancer and that we treat cancer. These are medical advances that need to be embraced. They need to be available for all individuals. They should not be available for some and not others. As we find out more and more technology and more processes that we can use to improve the lives of patients at risk for and with lung cancer, we should develop policy and legislation to support this progress. These life-saving and recommended approaches should not be available for some and not others. We've entered an extraordinary era in the treatment of cancer, and we cannot tolerate progress for some but not for others. Thank you.
Wait, before we take a vote, we do have someone here today that is signed to speak against the bill, so we want to give them an opportunity to come forward. But before you step down, I'd like to ask any of my committee if they would have a question.
Who's up first? Is it me? Oh, sorry. Thank you. I do have one question today. So in terms of the cost savings, I know we talked about the benefit to patients to be able to get in the forefront of treatment and really identify things that are going to work instead of going the traditional route. Can someone speak to the amount of cost savings that it benefits in order to catch this early and to be able to treat with precision medicine as opposed to allowing it to go on in the traditional form?
Yes, thank you. Thank you for that question. I'm happy to try to address that. I think the cost savings is immeasurable. To give someone back their life and to eliminate years of dangerous side effects, long-term chronic health diseases, and problems as an outcome of their either diagnosis or their treatment. But we did get we do have a health benefit mandate statement, and the fiscal impact actually came back that it is not expected to materially increase the total cost of health care in the Commonwealth. So it is not expected to raise any insurance premiums, and it is also not expected to materially increase administrative expenses of insurers. So that was wonderful news this morning because we are working with our insurance providers, and we are trying to get this right. We, I think, have an opportunity as a legislature to really have an impact on patient care. It's an exciting opportunity. It's one of the exciting parts of being here and having opportunities to really make a difference in the lives of our citizens. And so it was good news, in fact, to see that it's not going to cost the rest of our citizens anything to provide this kind of care. So thank you.
Representative Bentley.
Thank you, Mr. Chairman. My question, Doctor, is a lot of people who are not familiar with biomarkers, but could you explain if a person starts on direct chemotherapy, which is a misnomer there, what would happen if you later start them on a biomedical marker, how it could be a false positive maybe?
Well, you can certainly do it in that order. It's best to initially do the biomarker testing to find out if a patient has a targetable mutation. It's better to wait those 2 to 3 weeks. Sometimes it takes a little bit longer than that, but you certainly don't want to wait much longer than that. The problem is if you jump right into radiation therapy and chemotherapy, you can upset the immune balance of the body, and the drugs can be less effective if you do find a targetable mutation.
Yeah. I want the public to realize that. Thank you for that. Thank you.
Representative Justice.
Thank you, Mr. Chairman. I was just wondering if this bill, say you do a routine workup like so many of us should, and you're asymptomatic, you're showing no signs of a mass on imaging nor hyperplasia whatsoever, will this bill still cover routine periodic biomarker testing just in lieu of being healthy and staying on top of yourself?
This bill as it stands, to my understanding, is that we are specifically targeting patients with cancer with this bill. They have cancer, you do either a blood biomarker study, which is considered a liquid biopsy, or you do a tissue biopsy, and that helps guide your treatment. You can also use the biomarkers downstream to monitor the success of your treatment. And if the cancer occurs, and sometimes, as Leah suggested, you have to do a repeat testing of the biomarker to see if the cancer is mutated and try to find a way to work around the therapy that you're giving. These cancers, unfortunately, become smart. They find ways of steering around the treatments, and eventually they can recur.
Thank you. Thank you, Mr. Chairman.
If I could just add, this bill also covers pharmacogenetic testing, which is a less expensive way of determining whether or not a patient will respond a certain way to a medication or respond positively. And so this can be used in other cases with psychiatric meds, heart disease, you name it. If you determine that the patient responds well to, say, a psychiatric med, we can eliminate the need for, again, this trial and error, this period of instability in a person's life, and you get the right treatment at the right time. This is really cutting edge. This is something that Kentucky needs to do with our poor health metrics, our number one in lung cancer standing. It's time that we really do something cutting edge here in Kentucky and just provide the right treatment at the right time.
I totally agree, and I'm glad you guys are paying attention and drawing attention to this. Thank you.
Thank you.
I'd just like to state that it's pieces of legislation like this that make me very proud to be on this committee because it's life-changing. And Leah, your testimony was so powerful. Thank you for coming today. So at this time, if you guys would just stand up, and I want to have Tom Stevens come and give him a few moments to speak.
Thank you.
You guys stay ready. We'll bring you back up for the vote shortly.
Good morning, Mr. Chair. Sorry. My name's Tom Stevens, and I am the president of the Kentucky Association of Health Plans. First thing I'd like to say is just take note, the association is not opposed to House Bill 180. What the association does want to do is make sure that there are appropriate guardrails on the legislation so that it isn't misapplied. We certainly appreciate the opportunity to be here and express our concerns on the bill. We agree that biomarker testing is an important tool, and our members cover many biomarker tests consistent with medical necessity and clinical guidelines. In a conversation before this hearing started this morning, in particular with just one of our 6 major members, they indicated that their numbers over the last year show 100,000 biomarker tests that were done just in Kentucky. However, this legislation could significantly increase the number of tests that plans would be required to cover, including tests that have not been found to improve health outcomes. Broad testing leads to unnecessary testing, raising cost and lowering affordability for all enrollees. The use of biomarker testing should be based on peer-reviewed medical literature and be proven to materially improve the net health outcomes. These proposed legislative mandates would require us to apply standards and employ a much lower bar for evidentiary assessment, particularly Medicare local coverage determinations, and some clinical practice guidelines, both of which would require plans to cover an incredibly large and diverse number of tests which are not supported by evidence and may lead to patient harm through unnecessary testing, treatment, and other unintended downstream effects. House Bill 180 also includes the State Employee Health Plan and Medicaid, which have not been reviewed by the health mandate statement published this morning. The KAHP and our members have proposed amendments to develop a more focused bill promoting the effective use of biomarker testing. And we ask the committee to pause consideration of the bill today to allow time for this important information about testing costs, in particular the fiscal notes, assessing the program costs to the Kentucky Employees Health Plan and Medicaid before moving forward. And with that, I'm going to turn this over to my colleague, Scott Brinkman, who has a few other remarks on the proposed changes.
I'm Scott Brinkman with Connecting the Dots Policy Solutions, representing the Kentucky Association of Health Plans. And in furtherance of Mr. Stevens' testimony.
Could you please make sure your mic is on?
Is it on? It's on. Can
There
hear
you
me?
go.
There we go. We'll note that this is a mandate bill, and also note that the proponents talked about the efficacy of the testing in the context of cancer. So what we propose is to add some parameters to the legislation, specifically that the testing mandated pursuant to House Bill 180 be limited to testing in furtherance of detecting signs of cancer or cancer-related health condition. We also want to make clear that there has to be a medical necessity for the test. The legislation is not as clear in that regard as we would like, and medical necessity is a term of art that's used in any number of contexts within the healthcare field. We also suggest that the medical and scientific evidence that's used to determine medical necessity be narrowed a little bit. Two of the categories, one is consensus statements and one is Medicare local coverage determinations. There tends to be a fairly wide variance in terms of the evidence that is derived from those two categories. So we suggest that we limit to the FDA approved categories that are set forth in Section 2 of the bill, and also relative to FDA approved or cleared tests, that there be a demonstration that that those tests do materially improve health outcomes. Finally, we propose that the effective date of the legislation be moved from January 1, 2024 to January 1, 2025, simply because it is a mandate, and that would allow both the plans and the providers to configure their systems to accommodate the legislation, to hopefully, cut down, hopefully eliminate any abrasion, if you will, or confusion if this bill becomes law, and again, to allow both the plans and the providers to configure their systems to accommodate the mandate that's embodied in House Bill 180. So again, want to reiterate very carefully and strongly, we're not opposed to the bill, but because it is a mandate, we think the best policy is that anytime there be a mandate, that it be very narrowly tailored to the result that is sought. And in this case, clearly, the testimony by the proponents is that this is a test that is very, very effective in terms of possibly detecting signs of cancer. So we think that it would be appropriate that it be limited to attempts to determine if there's evidence or signs of cancer or a cancer-related condition, plus the other suggested parameters that just outlined.
I do have a question. Representative Callaway.
I just wanted to know if we could get those recommendations and guardrails. Can we get those?
Yes,
Sent us?
we sent a letter to Chairwoman Moser, and she has it, and we can provide the copy of the letter to every member of the committee.
Okay, thank you.
Thank you, Mr. Stevens and Mr. Brinkman.
Thank you.
Thank you for
Thank you very
coming.
much.
I'd like to ask Rep. Moser if she would to please come back.
Thank you, Mr. Chair, members of the committee.
Oh, you got a question? Oh, I'm sorry. Hold on a second. Representative Bentley.
Thank you, Chairman. Does the FDA have so many markers that they can approve treatment for lung cancer now? And is that positive outcomes when they do that, like from Health Foundation up in Boston?
I mean, Representative Bentley, I'm not familiar with that specific testing parameter that you're talking about, but I could ask and get some additional information to you later today.
But I think, maybe I'm wrong, but FDA, I think it is approved if you find so many markers. Maybe the doctor knows. If you do looking for markers for lung cancer, has the FDA approved therapy if you find so many markers?
Yes, absolutely.
That's my question.
Absolutely, yes. I mean, these are not experimental workups or treatments. These are workups and treatments that have been approved by national organizations that establish guidelines for state-of-the-art and standards of care.
So they have some positive outcomes from those biomarkers on lung cancer?
Yes.
Thank you. Thank you, Doctor.
Thank you, gentlemen.
Thank you.
Representative Moser? We already have a motion on the bill from Representative Bray and second from Representative Rourke. So, Madam Clerk, would you take the roll? Mr. Clerk.
Representative Bentley? Yes. Representative Bratcher?
Yes.
Representative Bray? Yes. Representative Burke?
Yes.
Representative Callaway?
Yes.
Representative Dotson?
Yes.
Representative Duval?
Yes.
Representative Frazier Gordon? Representative Justice?
Yes.
Representative Neighbors?
Yes.
Representative Rayburn?
Yes.
Representative Raymer?
Yes.
Representative Riley? Representative Rourke?
Yes.
Representative Sharp?
Aye.
Representative Swan?
Yes.
Representative Weber?
Yes.
Representative Wilner?
Yes.
Representative Whidden?
Yes.
And Chair Mosier?
Yes.
House Bill 180 has passed 19-0 with favorable expression, and the same shall pass on the House floor. Thank you, Representative. Do I take a motion for adjournment? Let's do it.